Okay, should we still wait?
Doc, we can start na po.
Okay, let's start na, di ba? And then, anyways, they're all in the slides, whatever I'm going to mention. So I'm actually here. Number one, we're here to fulfill the requirement of Dr. Viado. Now we have to meet synchronously. And then secondly, to entertain some of your questions also and for clarification. But if we run out of time, you can always PM and direct message me, okay? So remember in your first year, you studied, yung second sem nyo, you studied NeuroPD, right? So in NeuroPD is actually learning how to make a complete detailed neurological examination. What are the different parts of your neuro exam? Diba? You start off with your mental status, correct? So mental status, and then you have your cranial nerves, and then your motor system examination, you have your cerebellar test, checking for your abnormal and pathological reflexes, and then your sensory examination. So on top of that, you can also add your signs for meningeal irritation like nuchal rigidity, your Brudzinski and Kernig's. It's important that you know the neurological examination because you're going to be using this to diagnose a patient with a stroke. Okay, so in the lecture, I mentioned, remember that in the diagnosis of a stroke, based on the definition, so the history should be acute in onset and the symptoms should be rapidly progressing. And then, number two, you have to have an abnormality in any parts of the neurological examination that I mentioned earlier, or a combination of those abnormalities. So you can have a patient with dysarthria, slurring of speech, aphasia, facial asymmetry, weakness on the left or right side of the body, numbness on the left or the right side of the body, or a combination of any of those. Okay, that has to be satisfied. And then number three, the symptoms should have lasted already more than 24 hours. Because if it's less than 24 hours, you call it a transient ischemic attack. But it's as important, you know, as a stroke. Okay, because the risk factors and everything, the treatment are the same. And then fourth, so there is a problem in the cerebral vasculature, meaning the problem arises from something that happened, you know, to any of the blood vessels that supply blood to the brain. Okay, clear? Acute onset, rapidly progressing, and then you have an abnormality in the neuro examination, a combination of those abnormalities. So there's a problem in the blood vessel. Depending on which or what really happened to the blood vessel, so your stroke can be classified further into two major types. You can have a rupture of the blood vessel, you call that a hemorrhagic stroke, or you can have a blockade of one of the blood vessels in the brain, you call that an ischemic infarct. Clear? Okay, yung hemorrhagic, which happens about 30% of the time for all stroke patients here in the Philippines, 70% ischemic tayo, 30% hemorrhagic. So the hemorrhagic can be further subdivided into two types depending on the location of the hemorrhage, on where the hemorrhage actually occurred. So if it occurred in the subarachnoid space, the subarachnoid space is between the one of the layers, two layers of the meninges, yung arachnoid and the pia. So it's the space between the arachnoid and the pia. And this subarachnoid space surrounds the entire brain. It's kind of like a cushion or a protective covering for the brain. The subarachnoid space contains CSF, and it also contains all the blood vessels that came from the heart, the aorta, which stays there in the CSF space, subarachnoid space, for some time before they actually branch out and penetrate the brain substance. Once in the subarachnoid space, you call that collection of blood vessels as your circle of Willis. So if a blood vessel there ruptures, you call that a subarachnoid hemorrhage. But if the hemorrhage or if the rupture happens in the brain parenchyma already, once the blood vessel has already reached the brain parenchyma, then you call that an intracerebral hemorrhage. So far, you're following, right? If I ask you in the exam, what's the most common cause of subarachnoid hemorrhage? You're going to have to answer trauma. It's still the leading cause of subarachnoid hemorrhage. But if I ask you, what's the most common cause of non-traumatic or spontaneous subarachnoid hemorrhage? You're going to have to answer ruptured aneurysm for somebody who's older, like maybe in his 40s, 50s, or 60s, or AB malformation, ABM, so in somebody who's younger, in his 20s or 30s. Clear. So see, intracerebral hemorrhage, the most common cause is hypertension. So mga questions in the exam yan. So hypertension. And depending on the location, so there are 5 major common areas where hemorrhage can actually occur inside the brain. And these are your thalamus, these are your brainstem, cerebellum, any of the 4 lobes, frontal, temporal, parietal, or occipital, and then the basal ganglia. But the most common location will be basal ganglia. Okay, so on the other hand, so let's move to the other side. So if a problem is due to a blood clot inside the blood vessel, then you call it an ischemic stroke or an infarct. So and then your infarct or ischemia can be further subdivided into 2 types depending on where the blood clot actually arises. So if it came from the heart, somewhere else, not the brain, mostly coming from the heart, in a condition that you call atrial fibrillation, then you call it an embolic stroke. But if the thrombus would arise in any of the blood vessels in the brain itself, then you call it a thrombotic stroke. You're following? Okay, so the most common source of the embolus or the thrombus in an embolic stroke is the heart. That's a very common question in the exam. And the most common cardiac condition that will give rise to an embolic stroke is atrial fibrillation. On the other hand, the most common cause of a thrombotic stroke is atherosclerosis. Let's look at the symptoms. So in subarachnoid hemorrhage, since it's in the subarachnoid space that surrounds the brain, a lot of times you don't get to see a focal deficit. So there may not be weakness on one side of the body in a patient with subarachnoid hemorrhage. You're lucky if you get one. Pero sometimes, you don't see, a very obvious hemiparesis or hemisensory deficit in subarachnoid hemorrhage. The prominent symptoms will be, number 1, since there's a rupture of blood vessel, blood gets out of the blood vessel, it accumulates in the subarachnoid space. That will increase your intracranial pressure. And signs of increased intracranial pressure symptoms include headaches, vomiting, diplopia, altered sensorium, or even in some patients, loss of consciousness. So very prominent increased intracranial pressure. And then secondly, so since it's in the subarachnoid space where the meninges are there, so you're going to be seeing signs of meningeal irritation like nuchal rigidity, Kernicks, and Rudzinski. Okay, so in hemorrhagic stroke, aside from increased intracranial pressure, so you're also going to see hemiplegia depending actually on signs and symptoms, focal deficits, depending on where it actually happened. So kung cerebellum siya, then the patient will have dizziness, ataxia, drunken-like gait. So he will have difficulty doing your finger-to-nose test or your alternating pronation-supination test. Kung thalamus yan, since thalamus is a predominant sensory structure, so aside from some weakness, the sensory symptoms will be very prominent. So he will have pain on one side of the body, numbness, tingling sensation. So kung brainstem, unfortunately, a lot of them are comatose because your brainstem contains your wakefulness center, right? So it also contains your respiratory center and cardiac center. So a lot of them are intubated, so they will have respiratory failure and then comatose. But if you're lucky enough, you didn't get a big hemorrhage in the brainstem, then you see cross hemiparesis, facial asymmetry on one side, like for example, the left face, and then you're going to be seeing a hemiparesis or hemisensory deficit on the other side of the body. So cross siya. That's brainstem. And then basal ganglia, very prominent ang weakness, hemiplegia, or abnormal movements. Ang basal ganglia is concerned with control of movement, so you can get abnormal movements like tremors, like chorea, or hemibalismus. And then in the lobar, any of the lobes, then you can get, like for example, kung occipital lobe siya, baka walang weakness, but you're going to be seeing a visual field cut. The patient won't be able to see on the opposite side of the visual field. So parietal, very prominent ang sensory deficit. So in the temporal and frontal lobe, especially on the left side, you can get an aphasia. The patient may not be able to understand what you are saying, or he may not be able to express himself. So usually, no signs of increased intracranial pressure ang ischemic stroke. So as a general rule, but it could also be the other way around. A very small hemorrhage may not give you increased intracranial pressure, whereas a very big infarct, with a lot of edema may be associated with increased intracranial pressure also. Pero basta as a rule, so very prominent increased intracranial pressure, headache, vomiting, think of a hemorrhage more than an ischemia. Okay, so how do we diagnose? We've already mentioned. So you have to know the risk factors. The risk factors are classified into two groups. Meron kang modifiable risk factors. Modifiable, we mean you can modify them. And then you also have the non-modifiable risk factors. You don't have a choice. If you have any of those, you're at risk to develop an ischemic or a hemorrhagic stroke. So it's a non-modifiable. The most important is age. Age is the most important non-modifiable risk factor because as you grow older, the risk of you getting a stroke, will be higher compared to somebody who's younger. But although, this may not necessarily be the case nowadays because we're also getting a lot of younger patients with a stroke already. So aside from age, you have your sex. Females more protected because of your hormones. Men are more predisposed. But remember, a female who becomes menopausal already, your risk of getting a stroke is the same already as that of a man. So you're only protected when you are not menopausal yet. And then you have your family history. You cannot choose your family, diba? And then race. Blacks are most predisposed, and then whites are the ones who are least predisposed or susceptible. As Asians, we're in between. We're in between whites and we're in between the blacks. And then for your modifiable, those you can do something about, right? So the most important modifiable risk factor remains to be hypertension. So remember, hypertension, the most important modifiable risk factor. The most important non-modifiable risk factor is age. But aside from hypertension, you also have to treat the other risk factors like diabetes, dyslipidemia, smoking, alcohol, atrial fibrillation, so on and so forth. Alcohol is kind of controversial because if you will learn, if you are already in your cardiac module, so you're going to be learning that alcohol in moderation, moderate amounts, like 2 glasses of wine for men and a glass of wine for women, so it's protective. It has an antioxidant effect and it can actually protect you from getting a heart attack. The same applies to ischemic stroke. So alcohol in moderation can protect you from getting an ischemic stroke, but it's not going to protect you from getting a hemorrhagic stroke. So any amount of alcohol will predispose somebody to develop a hemorrhagic stroke. So don't drink na lang rather than too moderate drinking. Okay, so treatment are not the same for hemorrhagic and ischemic. So let's touch on hemorrhagic first. So sa hemorrhagic, so you have to do the following. Siyempre, there's a rupture, di ba? May bleeding siya. So you have to institute therapies or treatment that will control the bleeding. And examples of such medications are tranexamic acid and vitamin K being given intravenously. And then, di ba, so you want to stop the bleeding. And then secondly, you would also want to actually decrease the intracranial pressure. So yung mga examples of maneuvers that will decrease intracranial pressure include the following. So you can play with the blood vessels, diba? So on the arterial side, you hyperventilate the patient. So when you hyperventilate, diba? So you decrease CO2. CO2 is a very potent vasodilator. So if you decrease the amount of CO2 by by hyperventilating the patient, you will decrease the amount of CO2 and the blood vessels will constrict. Once the blood vessels constrict, there will be a decreased amount of blood flow to the brain, and that will actually decrease the amount of edema associated with the hemorrhagic stroke. On the venous side, you would want to actually facilitate outflow of blood coming from the cranium to the back to the systemic circulation by elevating the head of the bed of the patient to about 30 to 60 degrees. You're trying to facilitate outflow of blood through the help of gravity. And then if there's hemorrhage in the subarachnoid space, like for example, there's a hemorrhage in the ventricles leading to obstructive hydrocephalus, you can ask your neurosurgeon to actually put a drain, in the CSF space, in the ventricle, in a procedure that you call ventriculostomy, and that will help drain the blood from the CSF, into the outside. Okay, and then you can also decrease edema in the brain substance itself by administering your hyperosmolar agents like mannitol, hypertonic saline. Okay, steroids, no role in hemorrhagic stroke. Whether it's ischemic or hemorrhagic stroke, don't give steroids. And then of course, if there's a very, very big volume, especially in those, between 30 to 70 to 80 ml, so you can refer them to surgery for possible evacuation of hematoma. All possible sites may be accessible to surgery except for brainstem. So you don't recommend surgery to somebody with a brainstem hemorrhage, but you can recommend it to the ones with cerebellar, lobar hemorrhages, or even basal ganglia and thalamus. Okay, for ischemia, the treatment will depend on when you actually catch the patient. So if you get the patient within the first 3 hours to 4.5 hours, you can attempt to actually thrombolize or dissolve the clot by giving your thrombolytic agent. An example of which is your RTPA, your recombinant plasminogen, tissue plasminogen activator. But that has to be given within 3 to 4.5 hours. But if the patient is way past the 3 to 4.5 hours, is there another way that you can recommend to actually get rid of that clot? So yes, the answer is through mechanical thrombectomy. Within the first 12 to 24 hours, you can offer mechanical thrombectomy in those with a very large thrombus. So you can ask an interventional radiologist to actually remove the blood clot for you. But if it's more than 24 hours already, you cannot offer RTPA, you cannot offer thrombectomy already. So you're going to have to start the patient on an antiplatelet agent. So those that will inhibit your platelet to prevent further thrombus formation. And examples of antiplatelet agents, so nowadays include only 3. Before we used to have more. So now for your exam purposes, you just have to remember the following: aspirin, cilostazol, and clopidogrel. Okay, after 24 hours, when you can no longer offer RTPA or thrombectomy. So, but if you didn't offer the RTPA and thrombectomy in the first 24 hours or first 4.5 hours, then you can already institute your aspirin, cilostazol, or clopidogrel right away. Though that in those with a thrombotic stroke. So, but if the pathophysiologic mechanism of the ischemic stroke is due to an AF or atrial fibrillation associated embolic stroke, then the drug of choice will be your anticoagulants rather than an antithrombotic agent. And your anticoagulants include warfarin and your NOAC. Your NOAC, NOAC, stands for novel oral anticoagulants. So they're more expensive, but you do away with the prothrombin time monitoring that you actually usually do for patients who are receiving warfarin. So examples of your NOAC are rivaroxaban, apixaban, and your dabigatran. So there are more, but you just have to remember these 3 because those are the ones that are available in the country. Of course, so aspirin for thrombotic, your warfarin or NOAC for embolic. And then remember in ischemic stroke, I told you there's an area surrounding the infarct core. Infarct core, there's nothing you can do with the cells anymore. So they're all destined to die. But there's a penumbra, the surrounding area. You would want to save the neurons there. So you can give a neuroprotectant or a neuroprotective agents to push the neurons in the penumbra to help them survive. And then so eventually you can train these cells in this area to actually take over the function of the dead neurons in the infarct zone. And some of the neuroprotectant or the neuroprotective agents that you can use, you just have to remember three: citicoline, cerebrolysin, and neuro8. Before we also had more, but forget about those already. So you just have to remember this. And then one thing more, you don't really want to bring down the blood pressure in ischemic stroke right away during the first 5 to 7 days, right? So you want permissive hypertension. You want to allow hypertension to actually occur during the first 5 to 7 days because the brain is unique in the sense that it's up there on top of the heart, right? So, di ba? God is good. So He put the brain up there so that you have to use your brain before you use your heart, di ba? So when you love, use your brain, don't use your heart. So it's up there. So you need some sort of a hypertension to actually help the heart pump blood into the area with the ischemia. So you don't want to bring down the blood pressure right away drastically. Otherwise, you're going to be actually giving or providing or giving more damage rather than benefit to patients, with an ischemic stroke. And then, of course, all patients with ischemic stroke, they have to be on a statin. I mentioned that in the lecture. Your statins include atorvastatin, rosuvastatin, your simvastatin. So they're supposed to be cholesterol-lowering agents. But it will take time for your statins to actually decrease your cholesterol level. But on the other hand, your statins also have effects. They have immediate effects that will take place or take effect immediately. And these are known as the pleiotropic effects of statins. So they can provide vasodilatation, they have anti-inflammatory effect, they can also stabilize your endothelium and the membrane of the neurons. And these pleiotropic effects, are immediate. So you provide a statin, particularly atorvastatin, to a patient with an MI, whether it's MI or ischemic stroke, because of the pleiotropic effects. So specifically atorvastatin because it is the one that's most extensively studied, with a lot of trials proving that it could actually lower down a patient's risk of developing another ischemic stroke or MI. And then, of course, you have to refer the patient to rehabilitation medicine. For subarachnoid hemorrhage, so the definitive management is surgery. So that aneurysm has to be clipped or it has to be coiled to prevent it from actually rebleeding or re-rupture in the future. That's about it. Those are the ones that you really need to know for stroke and for exam purposes. Okay, questions? I expect a lot of questions. Wait, you're all sleeping? Di naman.
Doc,
sige.
Bakit po pala yung may tanong po sila?
Sige, go. We were...
Yung sa difference po ng hemorrhagic at ischemic stroke, bakit yung isa prevent nung moderate drinking, bakit po yung isa hindi? Ano po yung specific?
The exact mechanism why hindi natin alam what alcohol does to actually your blood vessels. So di ba sinasabi kasi na moderate amounts of alcohol has an antioxidant effect, di ba? Just like coffee. So because it's an antioxidant, it can actually help in terms of removing oxidative stress in atherosclerosis. So sa atherosclerosis kasi nagkakaroon ng a lot of oxidative stress like free radical formation. And since alcohol has some antioxidant effect, so it can actually help stabilize the plaque and then the membrane. Kaya less ka mag-prone to develop an MI or an ischemic stroke. Pero we don't exactly know what alcohol does to the blood vessel to make it actually more prone to rupture. Kaya hindi siya protective in terms of a hemorrhagic stroke. But it can protect you from getting an ischemic stroke or an infarct or an MI because of its antioxidant effect that will stabilize or actually slow down the progression of atherosclerosis. which is the pathophysiologic mechanism of MI and ischemic stroke. Nga pala, I forgot to mention. So I forgot to say this in the video. So yung, di ba, yung subarachnoid hemorrhage, it's associated with aneurysm. Yung aneurysm in subarachnoid hemorrhage, that's a developmental abnormality. You're actually born with the abnormal blood vessel already. Very weak or very thin tunica media. Pero yung hypertension itself, especially if you're chronically hypertensive, so it can also lead to microaneurysms. You can develop an acquired form of aneurysm because of chronic hypertension. And you call those aneurysms as Charcot-Bouchard aneurysm. C-H-A-R-C-O-T, Bouchard, B-O-U-C-H-A-R-D. And these are the aneurysms that will rupture in intracerebral hemorrhage. So matagal na siyang hypertensive, nag-develop siya ng microaneurysms that you call Charcot-Bouchard aneurysm, and they will rupture eventually in any of the 5 areas that we mentioned in hemorrhagic stroke, leading to an intracerebral hemorrhage. Tapos isa pa pala, remember I said in the definition, you have to have focal deficits, combination of abnormalities in your neuro exam. In some patients with stroke, ischemic stroke specifically, you can have a blood clot that's very, very small, that it will only affect a small blood vessel supplying a particular area of the brain with just a particular function. And in such patients with this very, very small blood clot, you can develop a stroke, with just one symptom, like purely hemiparesis. Wala nang facial asymmetry, walang dysarthria. Purely hemisensory loss, walang weakness, walang dysarthria. Or purely slurring of speech. Or purely ataxia, walang other combination of symptoms. And you call these types of infarct as lacunar infarct. L-A-C-U-N-A-R. So basta when you say lacunar infarct, the first thing that should come to your mind, it's a very small blood vessel infarct. So monosymptomatic lang siya. And then when you look at the pathology, you're going to be seeing lipohyalinosis because it's a very common exam question. Lipohyalinosis. There will be a lot of lipid deposition and hyalin deposition in the blood vessels of those with lacunar infarcts. Okay. Questions pa?
Doc, ako po.
O sige.
After po ng mag-ischemic stroke ng isang pasyente, and then we will give them clopidogrel and cilostazol, Doc. Yung clopidogrel at cilostazol, Doc, maintenance medications na po ba yun? Or at some point, we are going to stop the administration?
Sige, very good question. Initially, itong mga guidelines are saying nowadays that you would want to combine those antithrombotic agents. Kasi di ba antithrombotic, antiplatelet sila eh. May kanya-kanya silang mechanism of action in terms of like inhibiting your platelet action. So syempre, kung initially kakathrombotic stroke mo lang siya, so you would want to combine those medications para to avail of the different mechanisms in order for the patient to reduce his risk of another stroke because you're giving a lot of antiplatelets. Once stabilized, like say for example, around after 2 to 3 months, you can try to reduce, especially if the patient is already financially hard up, you can try to eliminate one by one, pero they have to be maintained on at least one antithrombotic agent for the rest of his life, unless there are other complications that will arise in the future that will prevent that patient or that will contradict the use of an antiplatelet agent. Okay, so this question was asked in the other class. What if thrombotic siya? Thrombotic talaga ka sigurado because you found the blood clot in the brain, but the patient already also has atrial fibrillation. So is it okay to combine both antiplatelet and anticoagulant? So the answer is yes. Okay, so you can combine antiplatelets and anticoagulants. Pero syempre kung may anticoagulant na siya, you don't want to use dual antiplatelets already. So just choose one. So aspirin lang plus the bigatran or clopidogrel plus the bigatran. So another question that was asked in the previous class, kung nag-develop ka ng hemorrhagic stroke ngayon, this time, are you also at risk to develop an ischemic stroke in the future or another hemorrhagic stroke in the future? The answer is yes. Unless you try aggressively to control the modifiable risk factors. Questions pa? What if the patient had hemorrhagic stroke and then 2 weeks after he developed an MI where aspirin is actually needed? So, pwede pa siyang bigyan ng aspirin? Diba? Hemorrhagic stroke siya. So, the answer again is yes. So, okay, remember this. For matters of the heart, when you love, so use your brain, diba? Before your heart. Pero in medical illness or problems, so matters of the heart take precedence over matters of the brain. So kung may MI at hemorrhagic stroke, mauna si MI. So of course, you're gonna have to treat both. Pero medications that are contraindicated in hemorrhagic, if it's indicated for the heart, you have to give it. I would like to ask sana if nagkaka-seizure din yung mga stroke patient. Yes, especially those with subarachnoid hemorrhage, since the hemorrhage will be in the subarachnoid space, di ba? So, and then the subarachnoid space is actually close to the cerebral cortex where the neurons are located. So that could irritate the neurons and you can develop a seizure. Yung mga embolic stroke, very common din na nagkaka-seizure sila. For the thrombotic, and the other intracerebral hemorrhage, they may not get a seizure immediately, but you can develop the seizure months to years after. Kasi di ba, the brain generally does not recover, does not heal completely. So if there's a lesion in the brain that could give rise to a gliosis or a peclat, di ba? And it's a gliosis that will lead to a seizure disorder months to years after. But immediately after a stroke in subarachnoid hemorrhage and embolic stroke, so seizure may actually happen. Questions pa?
Hi, Doc.
Yeah.
So, Doc, dito po sa WHO, ang stroke is rapid developing and meron kang focal disturbance that lasts for more than 24 hours. So, kung less than 24 hours, meron kang mild stroke.
Yeah, but you don't say, so if it's less than 24 hours, the symptoms resolve, you call it a TIA or a transient ischemic stroke. Try to shy away from using the term mild stroke. Kasi it connotes, especially to a layman, na okay, baka hindi naman siya ganun kadelikado, di ba? Because of the fact that you said, you termed it mild stroke. Sasabihin nila, ay baka naman hindi naman ganun kadelikado. Pero whether it's a stroke, a major stroke, or a TIA or a transient ischemic stroke, significant siya, you have to treat it right away because a TIA or a mild stroke heralds, it's actually it's a warning sign that a major stroke is already on its way. So treat aggressively.
Yes, Doc. So what is ganito po yung case? 22 years old, tapos bigla siyang nag-high blood, like sobrang taas, Doc. So possible ka po magka-TIA doon, Doc?
Oo, pero in a young patient na biglang nag-high blood, di ba? So kasi